Okay. All right. Okay. Let me just see if I can figure this out. Okay. Share my screen. Alrighty. Can you guys see the PowerPoint presentation on the screen there? Are you seeing the which one are
Using
you
the
seeing?
presenter mode, Dr. Pass.
Thank you. Always helpful. Let's see how I get out of that. 1 second. I think that will work. Okay. Are you now seeing? What are you seeing now? You're still seeing the presenter mode. Is that right?
Yeah. So there's the main slide, and then on the side.
Okay. Yeah. Yeah. All right. Hold on.
They just want to assign the different screen as being the default #1 screen.
Yeah. Okay. How's that? Is that? Are you now
Much
seeing?
better.
Perfect.
Much better.
Okay. Only took 4 tries. There you go. Okay. Good morning. Our last day of August. Imagine that. Let me just want to, I think we're saving this. Just 1 second here. I just want to stop the share for a second here. Sorry. Okay. All right. So let's get going. Last day of August. How exciting. All right. Okay, let me start by asking Dr. Sergey Babia of Russia and the Upper East Side of Manhattan. How are you this morning?
Good morning. I'm very well. How are you?
I'm good, thank you. So this is a patient, and I'm asking you here, what is the pacemaker problem here?
Sensing problem.
Okay, can we be a bit more explicit than that?
Well, I see that the pacemaker is pacing after the P wave right before the QRS, when it shouldn't be pacing.
Okay, when it shouldn't be pacing. So
yeah.
What do you mean? You're referring to, for example, the first 2 beats on the screen? Is that what you're talking about?
So yes, there is a P wave, and then there is a then it paces on top of the QRS, or right at the beginning of the QRS.
So
then
in other words, you're suggesting that the pacing doesn't need to occur there. Is that right? Is that what you're saying? You're saying it's. Let me not put words in your mouth. What are you saying?
Well, well, yeah, maybe it should pace, and that's why the QRS is there.
Yes.
So then the third, the third P wave, then there is no pacing where it should be, I guess.
So what do you think? What does this beat tell you about these beats and these beats? Well, it tells you that the patient has some kind of heart block, right? Because
yes,
these paced complexes are in fact necessary, or else this would happen. Right?
Yeah, true.
So the question I'm asking really is, why is this happening? This does represent a form of pacemaker problem. And what is the particular form?
So
I think you would agree that the pacemaker seems to be programmed in a manner where it will pace a certain number of milliseconds after every P wave, right? The PR interval in the first 2 beats and the last 2 beats is fairly similar. but then there's a P wave and there's no QRS. So presumably, the way this pacemaker was programmed, there should have been a paced complex here. Do you agree with that, Sergey?
Yes.
Right. So pacemakers are very smart. And if you tell the pacemaker, 200 milliseconds after the onset of the P wave, please pace the ventricle, it's going to do that unless, of course, it thinks the ventricle is beating on its own, right? It will always make sure in dual chamber pacing, it's a very important concept that whatever you set as the lower rate of the pacemaker, it will always make sure that the lower rate is at least that number, no matter what is going on in the atrium. It always wants to have AV synchrony, but it will never allow the lower rate or the lowest rate of the patient to go below the lower rate. Dual chamber pacemaking is ventricular based. So always the lower rate is equal to the lowest it'll allow. And I think we would agree that it's unlikely that we would have programmed the pacemaker to allow an RR interval this long, right? And so, because this is like a second in duration or more than a second. And so this is an example of oversensing, meaning that the pacemaker thought that there was something occurring in the ventricle and therefore did not pace following this P wave. Okay. So let's just explore the notion of pacemaker sensing today. So sensing is the ability of the pacemaker to see when an intrinsic depolarization is occurring. And so pacemakers sense cardiac depolarization by measuring changes in the electrical potential of the myocardial cells between the anode and the cathode, which are in most bipolar pacemaking leads at the very tip of the lead. And a pacemaker must be able to sense and respond. And so accurate sensing enables the pacemaker to determine whether or not the heart has created a beat on its own. And the pacemaker is usually programmed to respond with a pacing impulse only when the heart fails to produce an intrinsic beat at the rate that you have set the lower limit of the pacemaker. If the sensing is accurate, it will ensure that undersensing will not occur. And the pacemaker will not miss P or R waves that should have been sensed. And good sensing will ensure that oversensing will not occur and will not mistake extracardiac activity for intrinsic cardiac events, such as was demonstrated in that initial trace I showed you. And it provides for proper timing of the pacing pulse. And so let's take a look. So this is an example of undersensing. And in this case, the pacemaker does not see the intrinsic beat and therefore does not respond appropriately. So here we are pacing the V, and here's the marker channel. This is from a Medtronic tracing. So we're pacing. Now here is a QRS. And so there should not be a pacing spike here, right? Because the pacemaker should know that there is a QRS occurring. And so this beat is undersensed. This pacing spike, denoted here by a V-paced symbol, is a problem because it means that the pacemaker could pace inappropriately at the wrong time. In this particular case, it's pacing on a T wave, and we know what could happen, Sergey, if a paced beat is placed at the wrong time on a T wave.
Cardiac arrest.
From what?
Well, that's the same reason why we need to use synchronized cardioversion, not to put the shock on the T wave.
Right. You don't want to stimulate on the T wave because you could potentially induce torsade or VT or VF. And in fact, this is a very effective mechanism to induce VF in the cath lab when we're testing implantable defibrillators. And so here's another example. This is a sinus beat that conducts. And then if you look at this R to R interval, this is a rate of like maybe 150 beats per minute. It's unlikely that we see here that the pacemaker is programmed to pace at a much slower rate than that. But what's happening is that this pace spike to pace spike interval is probably the lower rate limit of the pacemaker. And these 2 beats were not sensed by the device, and therefore the patient is being paced. And essentially, this is an example of asynchronous pacing, or really looks almost like VOO. Remember, the first letter corresponds to which chamber is being paced. The second letter is which chamber is being sensed. And the third is additional features. In this case, it's being inhibited by intrinsic activity of the pacemaker. So this is undersensing. And this is an example of oversensing. So, and in oversensing, the pacemaker is detecting activity that is not really in the heart and is inhibiting the pacemaker. So here we have V-paced impulse, a V-paced impulse. Here is a V-sensed impulse, properly sensed. But then you see that the pacemaker is sensing something here that is not in fact here. There's no activity present. Again, the pacemaker is sensing something that's not there. Now, sometimes when you look at the electrogram, you can see what it is that the pacemaker is seeing. But the bottom line is that it thinks that there are 3 QRSs when in fact there's only 1 QRS. Here it looks like it's sensing the T wave. And this is a common problem in pacemakers, is that the pacemaker may oversense the T wave. And the issue of sensing is an extremely important one, both for pacing and for defibrillation, right? We don't want a defibrillator over-sensing and thinking there's activity when there is not. And so this is, for example, why when a patient has a defibrillator, it's routine to turn the defibrillator feature off when a patient is having surgery, because electrocautery can cause an artifact that can be interpreted by the pacemaker or the defibrillator as ventricular activity, and it could result in a shock from the defibrillator to the patient, an inappropriate shock. And in fact, inappropriate shocks are one of the really difficult problems of patients who have defibrillators, and one of the reasons why it's not a free ride to have an ICD. And so, and when leads break, it is not uncommon that artifact will develop on the lead that can result in oversensing and inappropriate activities. In this case, for a pacemaker, oversensing just results in non-pacing. But in a defibrillator, oversensing could be interpreted by the defibrillator as ventricular fibrillation, and that could result in an inappropriate shock. So undersensing or oversensing are both very serious problems for a pacemaker. And this is a nice little basic diagram of how this works. So again, in sensitivity, it's a little non-intuitive, but the greater the number, the less sensitive the device to an intracardiac event. And so this little fence analogy is often used. So if we're trying to sense or ability to see these trees beyond the fence, if the number is smaller, we can see more of the tree. If the number is higher or the fence is higher, we can see less of the tree. And so here is an example. So let's assume that this is a QRS, a PQRS, and a T wave, and that this is what we're sensing off of. And we see if we measure the amplitude of these complexes in millivolts, basically, if we set our sensitivity above the level of 5 millivolts, we see that we can't sense anything. In other words, when we set that at 5 millivolts, we're telling the device, do not sense anything that is less than 5 millivolts, meaning that the pacemaker will not sense the V or the T or the P wave. Okay, so paradoxically, when it comes to sensitivity, when the number is higher, we sense less well. Okay, sensing is worse. And similarly, and so in this case, this is an example of undersensing, because we would not be properly sensing the activity of the heart. Sort of conversely, if we set the sensitivity level at a very low level, the millivolts of 1.25, for example, in this little cartoon, and again, denoted by the little fence analogy, we can properly sense the QRS. We will not sense the P wave, which is good, but we are sensing the T wave. And so that's a problem because we don't want to oversense the T wave. And so that is, in fact, what was happening here. Was, for whatever reason, when we were, in the when we're doing our pacemaker testing or assessing a patient, we're oversensing here, and we are therefore, for whatever reason, there's some artifact on the ventricular lead that is telling the pacemaker to not pace. So this is an important concept that in pacemakers, the pacemaker virtually never malfunctions. Pacemakers are extraordinarily reliable. There are rare cases of devices that have to be recalled, but if you look at pacemakers and recalls and problems with systems over the last 30 years, 99.9% of the time, the problem is the lead, because the lead is basically the interface with the heart that is sending the information to the pacemaker. The pacemaker virtually never makes an error in its interpretation. It's just that the data it's getting, it's just like any other computer. If it gets good data, it's going to make the right decision based on the program that you set. If it gets bad data, it's not. And this issue of sensing is particularly important when patients are getting subcutaneous ICDs. And we'll be putting one in this week in a patient. And one of the most important issues in a subcutaneous ICD is, as you know, the lead is not inserted in the heart. So it's a very unusual technology where the lead and the device are essentially like an antenna or a large ECG lead. And we are asking the defibrillator in that circumstance to essentially use a similar tracing to the ECG in order to interpret the rhythm and properly decide if a patient is in VT or VF. And there have been a number of studies looking at how accurate that is. And as you would imagine, if it is undersensing, then patients are at risk for life-threatening arrhythmias that the device will undersense and not treat. And if it is oversensing activity, then the device could cause inappropriate shocks. And so when patients get subcutaneous ICDs, we typically, the company that manufactures the most commonly used one, which is Boston Scientific, has you do a special kind of EKG to simulate the signal that the device would see if it were in, because some patients do not have a vector that creates a large enough R wave that the device can reliably see the QRS. And so one of the things we do when a patient is getting a subcutaneous ICD, as we're going to do this week, and as we already have, is we screen the patient to make sure that the device has a good chance of being able to see the signal appropriately. And it turns out that large-scale studies in adults have shown that the sensing of these devices is remarkably good and is certainly very similar to that of a transvenous lead. And one of the interesting observations that have been going on, particularly in the adult world, is questions that's being asked is why it is that they have not been adopted as much as transvenous. And I think part of it is that it's technically more difficult to place a subcutaneous ICD, requires a lot more, shall we say, surgery. But I think it's also just a general familiarity and a disbelief that it can be as good in its sensing abilities as a transvenous system. But actually, most of the literature suggests that they're equally good. So this is an example of oversensing. Okay, are there any questions about this issue before we move on to a different area completely? Okay. Let's move on now to another tracing. Okay. This is an example of ablation of an accessory pathway. And why don't I I think I see, actually, why don't we have a visitor today? I think, or we did have a visitor. I guess he stepped out. So why don't we then ask Dr. Obiaka? Hello, Uzo, are you there?
Morning, Dr. Paz. Yes, I am.
Hi. For some reason, Uzo, it always says that your other Obiaka is connecting to audio. the whole meeting. Anyway, Uzo, we're on this screen. So I showed you where we turned radio frequency energy on. Where on the screen does this accessory pathway block, and how do you know that?
So looking at the tracing before RF was applied,
Yes.
the earliest conduction was in the.
Well, I'll tell you, this is a somewhat unfair tracing in that the His catheter seems to have fallen out of position, so it's hard to tell. But I think we can say, however, that it is not early in the coronary sinus pairs.
Yeah.
The AV time is quite wide, and the ventricular electrogram is later the further out we go.
Because it looks, based on that tracing, it looks like it was earliest in the His, in the proximal His. But if you're saying the catheter is
it's really not in good position. The His only, unfortunately, has an A. Dr. Love had no time to put it back in.
Okay, so I have to look for something else.
But again, I'm not asking you that question. If I were asking you that question, I would not show you this tracing. I'm asking you only, where do you see that the pathway, in what beat on this tracing has the pathway been successfully ablated? Because it does get successfully ablated in this tracing.
I would say in the second beat. So after RF is applied, in the first beat, it doesn't look like it's been blocked. I feel like there's still some pre-excitation in the first.
Yep, I agree with that statement.
But by the second beat, it's no longer pre-excited.
That's correct. 1 second. So I got a text, I apologize. Okay, so yes, so what's happening here, and you can see this the reason I included this tracing, I thought it was a very nice example of how the ECG is a very good good way of detecting when the pathway has blocked. So RF goes on and we see pre-excitation, and then we see a non-pre-excited beat, and in fact we have 2 in a row. And the other thing that we see is that, remember that when we're mapping the pathway, the catheter should be on the AV groove, and there should be both an atrial and a ventricular electrogram. So presumably this is a ventricular electrogram that is preceding the onset of the QRS, and we see how the atrial and ventricular electrograms separate once the pathway has been successfully ablated. So basically on the second beat in sinus rhythm following the starting of radio frequency energy, we see loss of pre-excitation consistent with pathway blockage. So now we see a very clear A and V. So if you were wondering where does the A end and the V start, you can see here, this is what the ventricular electrogram appeared to look like at that site and the atrial. But remember, when we're at the pathway location, theoretically, we should have the A and V as tightly connected as possible. And so here we see the A and the V separate, consistent with accessory pathway ablation. And this is an example of how we measure the signals. And we're always trying to find the ventricular, when we're in sinus rhythm, we're trying to find the ventricular electrogram. We want to see an A and a V on the signal, suggesting that you're on the annulus, because remember that in theory, the pathway should be at its narrowest portion when you are on the annulus of the valve. And you want the ventricular electrogram to precede the onset of the QRS by as many milliseconds as you can identify or find. So after Dr. Love moved the catheter around about 30 or 40 locations on the tricuspid annulus, he was able to identify an area in the right lateral position, posterolateral position, where the onset of the QRS, of the ventricular electrogram, preceded the onset of the QRS, denoted here by this line, by up to 40 milliseconds. And that would be, generally speaking, we would want to be about 30 to 50 milliseconds we would say this is pre-systolic. By that, we mean the onset of the QRS. So that is a good signal. And the fact that the pathway disrupted in less than a second from turning on the energy is often a good sign that you were in the right place. Generally speaking, if the pathway goes away in less than about 2 to 3 seconds from the time the radiofrequency energy is turned on, that is generally a positive sign that you are probably in the correct location. Okay. All right. As Marvin Gaye once asked, what's going on? Why don't we put this question to Dr. Barris? Is he on the line today?
Good morning. I'm on the line today.
Hello, David.
Good morning. So I'm just taking a peek here at our three tracings that we have.
And I would just mention these are not simultaneous. This is like a continuous tracing. I'm sorry, it's a little confusing.
Got it. So just starting at the top, I see a P wave, and then a looks like a narrow QRS, and then a T wave, and then I see some sort of there's another wave over here. I'm not sure whether this is a paced beat going on, because I see a small spike, and then a wave, and then I have a pretty long gap, and then I see a regular P, and then P wave, QRS complex, T wave, and then another one of those spike, and then additional beats. I don't see those similar beats in the second tracing that we're looking at. And then in the third tracing that we're looking at, I see, I'm looking at this rhythm, and I see kind of two beats close together, and then there's a much larger gap, another large gap, and then again 2 beats that are quite close together. Those,
yes,
maybe like a, and those are narrow complex. So kind of thinking about what's going on. I mean, so we do have some sort of pacemaker going on, and we wouldn't have a pace setting that was this long of a gap. So perhaps we're oversensing, and that's why we're not getting. We could have both oversensing and undersense. I mean, I guess it's a little weird to have both over and undersense. That doesn't really make sense. But perhaps we are having in at least the second line. We could be having oversensing, because I'm not seeing any paced beats happening. And in the top line, it could be something like like in the top line, it could be an undersense, because we have a paced beat right after our regular conduction.
Right. So let's just take a step back. There is, in fact, no pacing here, although it does kind of look that way. I appreciate that. What this is just atrial bigeminy. Okay, so this is a sinus beat, as you rightly said. And then if we see on the end of the T wave, this small P wave, and notice that the PR interval is a little longer. And we also notice that this QRS, which you thought looked like it was a paced complex, and I certainly understand why you're saying that, but it is in fact what this is aberration as a result of a very early P wave. Remember that the PR is longer, which is demonstrating a very commonly referenced, shall we say, quality of the AV node, which is that it has decremental conduction. So as we when we put a premature impulse in early, the PR interval is going to get longer, because that's the whole process of extra stimulus testing. As we get earlier and earlier, the AH or the PR interval lengthens. And so here we have a sinus beat, a premature A, which is conducted with a long PR and an unusual appearing QRS complex, probably because this coupling interval is relatively short, although not that short, right? I mean, this is a rate of about 100, maybe 150 beats per minute. So most people should be able to conduct that P wave. It's certainly most young people, although I think this is actually from an adult who seems to have some kind of sinus node dysfunction. Again, we see another another A on top of the end of the T wave, which is conducting with a longish PR and this unusual looking QRS, and that goes on and on. Then in the second tracing, the patient is continuing to have these P waves, but they are not being conducted, presumably because the AV node is unable to conduct at this coupling interval. And this coupling interval is too short for the AV node to conduct. And so, and if we were to measure the interval from this QRS to this P wave versus this QRS to this P wave, you notice in your mind's eye, this is a slightly longer interval than this one. And so this is just a little too early for this particular individual's AV node to conduct. And so what we're seeing here is sinus rhythm with blocked PAC in a pattern of atrial bigeminy. And so basically what that means is patients' overall ventricular rate is going to be very slow. And I'm bringing this, I thought this was an interesting case to show because this is a very typical problem that we'll see in the NICU. Not to this degree with such a slow heart rate, but very commonly babies who have atrial ectopy will have atrial bigeminy, and the second beat will not conduct, and it will result in an overall effective heart rate. In this case, it's a very slow heart rate, but oftentimes we'll see heart rates in the 70s, for example, in the NICU in babies like this, and this gets neonatologists very frightened. But in fact, it's not an unusual finding. And in this case, we notice that this P wave is now occurring a little later than the P waves in this tracing or this tracing. And so the QRS is, we still have a very long PR interval, but the QRS is more normal in appearance, presumably because the coupling interval isn't as tight. And so the bundle branches presumably have enough time to allow for conduction. And so the QRS morphology looks a lot more like the sinus morphology, because presumably, although the AV node is taking a long time to conduct, the His Purkinje system looks kind of similar to the QRS. So this is an example of atrial bigeminy. All the beats have atrial bigeminy except for this one here, which is in fact why this RR interval is so much shorter, because what's happening when you have a PAC is it's resetting the sinus node, causing a sinus slowing. Here there isn't one, so the P2P interval is more normal in appearance. So this is a nice example of atrial bigeminy.
Dr. Paz, this is Neha.
Neha, there's some issue with your audio.
There is a phenomenon where you can have 2 to 1.
Neha, having trouble hearing you.
Oh, can you hear me now?
That's better, yes.
Never mind.
Hello? Neha?
It's okay, Dr. Paz. I don't know why there's some issue with my audio.
That she'll discuss offline.
I was just asking that
There's a delay, so she's actually not talking now.
can somebody
Okay, it
just say,
sounds like she's talking now, but okay. Sorry, Neha, I guess maybe you got Uzo's phone. Okay, sorry. We'll try that next time. Okay, so this is a Fontan patient, and now that we know Uzo's phone is working so well, let's ask Uzo, what do you think about this? This is a old Holter tracing. By the way, these are all tracings from these books that you were kind enough to give me when you were cleaning out the fellow's office a couple of months ago. So this is a very old tracing from a patient many, many years ago. But
okay, Dr. Paz, maybe we'll ask the fellow who gave you the book to come take you back.
those books are long gone. So what do you think, Uzo? What do you think about this Fontan patient?
So looking at this is a Fontan patient. The heart rate seems to be about a little more, maybe 170 thereabouts.
Uh-huh.
Which for Fontan is on the high side, quite
For
high.
sure. Uh-huh.
So I would say this patient is, because it's a Fontan with a heart rate that's elevated. The tracing, I don't see the, like I'm trying to count the conduction, but I would just say this is likely atrial flutter.
Okay. I probably would agree
Um,
with that. The
and
first important
then,
point that, and I'll just emphasize what you just said. First important point is when you see a Fontan at 170, the chances that that is sinus rhythm is very close to zero. So particularly at 7:05 p.m., unless they're in a basketball game or something. So the point is and flutter is certainly a very good guess, since that is in fact the most common problem, or what is sometimes referred to as intra-atrial reentrant tachycardia. So just to reemphasize that point. So go ahead, Uzo. Sorry.
so on the first tracing, it seems to be like a regular, I would say maybe 2-to-1. But as you keep going, there seems to be some variability in the second tracing in the in the block of the conduction. So it seems to be varying from, because the heart rates slows down. So I would say we're just going back and forth from a 2-to-1 to maybe 2-to-3, 2-to-4 conduction with continuous slowing of the heart.
Yep.
And then on the third tracing towards the middle, there's like almost like a pause, it
Yep.
seems.
That's right.
With
So
extreme Brady.
that's right. So it looks almost like the tachycardia has completely stopped. It's suddenly terminated. You have a very long pause. And then what are you seeing in the last tracing, Uzo?
And then it seems like we go back in
Yes.
in the next to the last tracing, and then in the very final tracing, in the first few beats, in the first beat, I don't see a P wave. In the second beat, there seems to be a retrograde P.
Are you looking at, where are you looking at, here or here?
Yeah,
At
the very
bottom.
last. Yeah, the very
The
bottom.
very bottom, yeah. So basically what we're seeing here is some kind of it looks like a junctional rhythm, right?
Yeah.
And then at the end, the sinus P wave
Sinus
sort
P
of seems to
comes
come
in.
out here, right? But we have an extraordinarily long pause. So in ancient times, like 10 years ago, or 10 years ago, actually more like 30 years ago, this would sometimes be referred to as Tachy-brady syndrome. That's a term that used to be used for people who are susceptible to atrial arrhythmias, but who have sinus node dysfunction. So let me ask Neha, can you think of another congenital lesion which might be afflicted by so-called Tachy-brady syndrome?
I'm not sure. I'm thinking.
So the one that I'm thinking of is people who've had mustard or Senning operations. So in Dr. Zady's ACHD population, sinus node dysfunction, we talked about this a number of weeks ago, is a very common problem. So, and they also are often afflicted by atrial flutter or intra-atrial reentrant tachycardia. So this is a nice example of somebody who has, and you know, the reason that people with bradycardia, one of the reasons that they are susceptible to tachycardias is because sinus rhythm itself is a good antiarrhythmic rhythm. It essentially suppresses atrial ectopy, which allows for atrial reentry. And so in this case, we see that because of the sinus node dysfunction, when the atrial tachycardia terminates, there's this extraordinarily long pause during which you would expect a patient might faint, although maybe they were asleep, so they didn't even know this happened. But this would generally be an indication for two things. First of all, an ablation, but secondly, a pacemaker. You don't really want to allow Fontan patients to have these types of pauses. Would be very hemodynamically embarrassing, both the tachycardia and the pause. This could, in fact, even be life-threatening. This type of rhythm can sometimes degenerate into VF in sick Fontan patients. So this is a very worrisome type of a tracing to get on a Holter, for example. You would definitely want to intervene in a patient like this. This is a patient who you bring in and you get a pacemaker put in, and then you take them to the lab and you try to ablate this flutter. You could do it in the other way too, but sometimes when you get rid of flutter, patient ends up like this with lots of long pauses. So you sort of would like to have a pacemaker on as a backup. And remember, it is not easy to pace a Fontan patient in the cath lab because there is no access to the ventricle from a transvenous perspective. So the only way you could pace the ventricle would be retrograde across the aortic valve, or if you were lucky and there was a Fontan fenestration, you could go through the fenestration and pace the V, but most older Fontan patients do not have a fenestration. And so probably the proper sequence would be to place a ventricular pacing catheter and ablate the atrial flutter in this case. All right, it's 7:45. I think we'll stop here. Thank you very much for joining. And any questions about what we've discussed so far? Guess not.
No
All right.
question. I'd have a question regarding just the isoelectric point I had emailed you about.
Yes. I
yeah,
didn't
what-
understand your question, Dr. Morales.
So when you're using for ST segment depression versus elevation, do you utilize the TP segment or the PR segment as your isoelectric line?
I think I usually use the PR, honestly. I think that's a more standard way that people use. And I honestly, to be completely frank, I'm not sure what the issues are between one or the other. I'm sure that there's a whole literature on this in the adult world, but I'm not as well versed on that, to be honest with you.
Awesome. Thank you very much.
Okay, thanks for joining us today. All right, guys, have a great day. I'll see you inside in a few moments.
Thank you.